So let's begin our today's topic, which is leishmaniasis. Leishmaniasis, as the name shows, is the condition of caused by the leishmania. Leishmania is the parasite, so it's a parasitic infection caused by the leishmania. So the name leishmaniasis, or is the condition, asis is the condition of caused by the leishmania. So it's the condition caused by leishmania, and if you see in this diagram, that's the leishmania, and this leishmania is very commonly affect the reticuloendothelial system. So reticuloendothelial system, reticulum is the meshwork or network, and it affects the reticuloendothelial system. It affects the macrophages, monocytes, all those cells are affected by the leishmania, which are the part of the reticuloendothelial system. We have also the lymph nodes and then the macrophages, which are attacked by the leishmania. The life cycle of leishmaniasis, it has two stages, human stage and the sandfly stage. It is caused by the bite of the sandfly. So it has two cycles, or the cycle has two stages. We have the human stage of leishmaniasis, and this human stage begins with the bite of the sandfly. And this bite of the sandfly, it causes infection of the neutrophil. It infects the neutrophil. As I mentioned, it attacks mainly the reticuloendothelial system, and then it affects the neutrophils. Neutrophils are the white blood cells and these neutrophils play a very important role in fighting the infection. So when they are affected, they are destroyed. The ability of the person to fight the infection, it becomes less and less. So it infects the neutrophils. Neutrophils are the white blood cells. And then it has all these stages keep on infecting the neutrophils. It enters the neutrophils and then it leaves the neutrophils, attack the other cells, and this way it keeps on propagating. And then from the neutrophils, it goes to the macrophages. Again, macrophages are a very important part or cell of the inflammatory cells. They are known as inflammatory cells. They play an important role in fighting an infection. So if you see, all these are the parts of the reticuloendothelial system, which are affected by the leishmania. So after the bite of the sandfly, it enters the neutrophil, and then from the neutrophil it infects the macrophages. From the macrophages, now the pro-mastigote, which are injected into the body by the sandfly, they change into a mastigote. So pro-mastigote, which is injected enters the human body by the bite of the sandfly, it attacks the neutrophils, and then from the release of the neutrophils, it enters the macrophages, and then from there is change of pro-mastigote to a mastigote, and this is the diagnostic phase of the humans, where the diagnosis, we can find the a mastigote and we can tell that the person is infected and has leishmaniasis. So here you can see this is the diagnostic stage. So enter life cycle has human stage, begins with the bite of the sandfly that injects the promastigode. These are the promastigode that enters the human body with the bite of the sandfly. This promastigode enters the neutrophils. Neutrophils are the white blood cells which can attack the or fight infections. From this infected neutrophils, then the promastigode, they release and they attack the macrophages. And inside the macrophages, then there is, you can see the replication is taking place inside the macrophages. Now there is one promastigode grows into the 4 promastigodes. So it's a proliferation of promastigode takes place, and then it converts to a mastigode. And this is the diagnostic phase in which if the blood is tested, we can find that the person is infected with the leishmania. Now, once the replication occur, you can see there is bursting of the macrophage and release of now not the promastigode which enters the human body. Now it's the release of a mastigode, because inside the macrophage, promastigode changes to a mastigode due to the proliferation, and now these a mastigodes are released. And now when the sandfly bite the person again, the a mastigode will be taken up by the sandfly. Here again you see now with the sucking of the blood, with the bite of the sandfly, now these amastigodes enter the sandfly again. And now the cycle stage of the sandfly begins, where the amastigodes now again change into the promastigode, and then it's again injected into the human body. So simple life cycle, it's in the 2 stages. We have the human stage, we have the sandfly stage. In the humans, the promastigodes are injected with the bite. These promastigode attacks the neutrophils, then the macrophages, multiply in the macrophages, change into amastigode. These amastigodes are taken up by the bite of the sandfly. In the sandfly, they again change into promastigode and then injected into the human body again. And it attacks the reticuloendothelial system, which consists of the macrophages, and they attack the neutrophil. So mainly the defensive mechanism or defense system of the human body is affected. So simple life cycle: promastigode to amastigode, amastigode to promastigode, and it's between the human and the sandfly. Next, the cutaneous leishmaniasis, as we already have in the other lecture talked in detail about the post-kala-azar or the visceral leishmaniasis. It affects different viscera of the body, and it can damage those viscera, and the mortality rate is high if not treated. The second most commonest parasitic infection besides the malaria, causing the deaths worldwide. It has a wide distribution worldwide, and the different parts of the world, they have leishmaniasis, and depending on which area the leishmaniasis was found, it is usually named after that. We have Amazonian leishmaniasis, tropical leishmaniasis, African leishmaniasis, there is Braziliensis leishmaniasis, so different parts. If it's from Brazil, tropical areas, from the America, Africa, so it's named after that area. So different types of, it's common in different parts of the world. So cutaneous leishmaniasis is the leishmaniasis that affects the skin. Cutaneous is the skin, and it is usually occur as a papule. A papule, it develops on the skin first a few days after the bite. At the site of the bite, the papule is formed. Then after the papule, we have the nodules. From papule, it develops to the nodule. So that's all the diagrammatic presentation. From papule, it goes to nodule. Then it becomes the ulcer over some weeks or months. So first it's papule, then becomes the nodule, and then the nodule becomes the ulcer. There is ulceration, there is actual lesion you can see at the site after some weeks or the months. So cutaneous lesion of leishmaniasis begin as papule. Then the nodule can become the ulcer. Ulcer is the lesion which is eroded or ulcerated. You can see the margins of the ulcer. So that develops here, raised margin and indurated. That's the ulcer. So papule, nodule, and then the ulcer develops after the weeks or the months. That's the presentation of the leishmaniasis, really bad cutaneous leishmaniasis. It has, you can see now this lesion is all ulcerated with the induration and the raised edges. This is not a papule or nodule anymore. It's ulcerated lesion. So that usually is a condition after a few weeks or the months. So this is not the new case of the leishmaniasis. You can see again there is ulceration present here also. It can be single or multiple lesion. There we have multiple lesion, but it can be a single cutaneous lesion of the leishmaniasis, like maybe on the nostril. If there is just a one lesion, it is also possible. In this case, you can see a child with multiple lesions, or now we can say it's the ulcerated lesion. So it's an old case of leishmaniasis. Satellite lesions. Satellite lesions are the lesion in which we have primary lesion, and then surrounding that lesion in the close proximity we have the other lesions present surrounding. So we have the main lesion, and then surrounding in the periphery we have other lesions present. That's the satellite lesions. And the size is about 0.5 to more than 3 centimeter. That's the range. So it's the big lesion. You can see it's not a small, it's a big lesion ranging from 0.5 to 3 centimeter in diameter. So it can be single or multiple. We have satellite lesions, which are the lesions when there is main primary lesion and surrounded by these lesions around that. And then it's from 0.5 to 3 centimeter in diameter, or even more than 3 centimeter. It can be single or multiple. First, at the site of the bite of the sandfly, we have the papule. Then the papule become nodule, and after the period of time changes occur, it becomes ulcerated with the raised margin and induration. And again, it's the infection caused by the bite of the sandfly, which inject the pro-mastigode into the human body, attacks the reticuloendothelial cells, it attacks the neutrophils, from the neutrophils to the macrophages, multiply in the macrophages, keep on affecting different cells, multiple cells, and then after the release of from the promastigote to amastigote, it releases out and then again taken up by the bite of the sandfly, in which the amastigote again are converted into the promastigote, and then the cycle keeps on going. And different parts of the world has this disease, and it's the common infectious disease with the high mortality rate. The diagnosis of, if you magnify the lesion, we saw that's the ulcerated lesion, really bad lesion with the raised edges, indurated edges, and that's the lesion. So cutaneous leishmaniasis. Demonstration of a mastigote. So as I mentioned in the previous diagnostic stage, when we talked about the life cycle, the conversion of promastigote to amastigote is the stage where the diagnosis can be performed. We can diagnose that this is the patient with leishmaniasis. So demonstration of amastigote in the lesion is helpful in the diagnosis of cutaneous leishmaniasis. So sample from the lesion, if it shows the amastigote, that is diagnostic. Again, it's due from the microscopic examination of the lesion. Here you can see the microscopic histological picture. Then from the aspirate, any pussy discharge, any fluid discharge, if we aspirate that and examine it, we can also find the amastigotes. And then also the skin smears. The smears of the skin which are affected by the leishmania, that can also tells us or help us in the diagnosis. So if there is a skin lesion present like this, skin lesions like this can be due to some other diseases also. To find out whether it's due to leishmania or due to some other infection, we need to diagnose, and the diagnosis is by the finding of amastigote, which are maybe due to the aspirate we get from the skin smears, and also by the to find out these are the microscopic appearances that tells us the presence of amastigotes. Also, finally, the biopsy. Biopsy is also helpful in the diagnosis of the leishmaniasis, and that is also can be performed. So, slit skin test, aspirates, and biopsies, all these can help us to diagnose the leishmaniasis. These are all the microscopic appearances. That's what you see with the skin smear. There's the aspirate, and there's the biopsy of the tissue which is infected by the leishmania. And then another method of diagnosis is PCR, polymerase chain reaction. So to summarize, is the diagnosis can be done by the finding of amastigote, done by the skin smear, aspirate testing, and the biopsies all gives you the different appearance on the microscopic examination, and also by the polymerase chain reaction. Treatment of cutaneous leishmaniasis, you can see a child with a very bad case of leishmania. The dried up lesions are present. They are not like a fresh lesion with the discharge, but they are the dried up lesions. Treatment is for all forms of cutaneous leishmaniasis. The different forms are present. I already mentioned, depending on the area where the disease is present or it's found, the causative organism can be different. But for all forms of cutaneous leishmaniasis, a pentavalent antimonial 20 milligram per kg body weight for 20 days is used. For Leishmania viania, which is guyanensis, the pentamidine is ethionate, 2 injections of 4 milligram of salt per kilogram separated by 48 hours. So 2 injections are given, which are at the interval of 48 hours, which is due to the Leishmania viania. Then we have Leishmania ethiopica, which is in the Ethiopia. So all these are named after the region they are present in Vienna, in Ethiopia, in Brazil, in tropical region. So treatment may be for all forms. We have a pentavalent antimonial drug, which is 20 milligram per kilogram body weight for 20 days. But there is some difference between the Leishmania viania and Ethiopica, and in this we have paromomycin, 16 milligram per kilogram daily. So for all forms, we can use pentavalent antimonial with the few exceptions, which is viania and Ethiopica, and then we have paromomycin and pentamidine is ethionate. Next, post-kala-azar dermal leishmaniasis. What are the clinical features? Kala-azar leishmania was the visceral type of leishmania which affects different viscera. Very commonly, when we talked about this topic in another lecture, we said that it affects the liver and spleen and cause really bad hepatomegaly and splenomegaly and cause different complication and is associated with very high mortality rate. So after that type of leishmania, which is post-kala-azar leishmania, we have some dermal complications, and that's the picture you can see. That's the appearance of the leishmania, which is the post-kala-azar dermal leishmaniasis, and it affects the dermis layer of the skin, derma, which is the second layer of the skin. We have epidermis, dermis, subcutaneous, so it's the dermal leishmaniasis. There is, we have hypopigmented macules. Macules are the areas which are hypopigmented, little less pigmented. They can be easily differentiated from the normal skin. So we have nodular, you can see the nodules present, and then we have hypopigmented macules. That's the macule. You can see it's the hypopigmented as compared to the surrounding skin. And then we have the nodules. Nodules can be, we have exophytic and endophytic. Exophytic, which are outside, comes out, and endo stay inside. Here, that's a very good diagrammatic presentation of exophytic nodule that is coming out, and you can see, and they stay inside, and that's the endophytic nodule. So presentation of dermal post-kala-azar dermal leishmaniasis. We have macules, we have nodules. Nodules can be exophytic or they can be endophytic nodules. Diagnosis of post-kala-azar dermal leishmaniasis. We have the lymphocytes, histiocytes, and the plasma cells. So lymphocytes are the cells of the lymphatic system. Lymphocytes are the cells, lymphatic cells, and then histiocytes are the tissue cells, and the plasma cells are present. There is RK39 and other serologic tests are present or they are positive in the post-kala-azar dermal leishmaniasis. So different mutations or cells, the tests are positive via RK39 and other serologic tests. Serologic tests are the tests performed on the serum. So different serological tests are positive. Pentavalent antimonial for 60 to 120 days. So the treatment of post-kala-azar dermal leishmaniasis is for 60 to 120 days. For, as we mentioned, the treatment of simple cutaneous leishmaniasis is for the 20 days. But this is long treatment for this post-kala-azar dermal leishmaniasis for 60 to 120 days. So it's a long treatment. Non-compliance. Oral miltefosine for 12 weeks is again used. If the patient is not compliant or not taking the medication properly, then we should go for oral miltefosine for 12 weeks. So if the non-compliance is present. Now the diffuse cutaneous leishmaniasis, when the involvement of the skin is more diffuse, what are some changes that are taking place or what's the pathogenesis that leads to more diffuse involvement of the skin? So it is between the circulation and the dermis. As we all know now that the cycle of the leishmaniasis is between the human and the sandfly, and it affects, inject the pro-mastigode that are affecting the neutrophils and the macrophages, which are all the or the reticuloendothelial system. So the main involvement or the main cells targeted by the cells which are the part of the inflammatory system or that helps in fighting the infection. So in the blood we have the CD4 and T cells. T cells are the type of the lymphocyte. We have B lymphocytes, we have T lymphocytes that play a very important role in the immune system. So CD4 and T cells, and then we have CD8 and T cells, and also the B cells. All these are the important cells which play an important role in the immune system. And in the circulation they are targeted, and then these go into the dermis, in the skin layer or the dermal layer of the skin, and then they bring some changes that can cause the diffuse cutaneous leishmaniasis. These can help CD4 and T cells in the dermis bring some changes, mutation, TBET and GATA3, and this helps in the recognition of, and it affects some marker cells like RMO markers, M1 marker, M2 markers, and these, and again again helps in the parasite survival, and ERK half. These are all the changes that are, we have T helper cells 1, T helper cell 2, immunoglobulin G1 and immunoglobulin G4, which are taken up and they help in the survival of the parasite taken inside. Anti-inflammatory reaction is there. We have decreased complement activation. Complement system again plays an important role in the immune system. So all these changes which you are looking at, or the pathogenesis, is the cells attacked by the leishmania, the reticuloendothelial cells, and the effect of that attack is decrease in the ability of all those cells which are present in the blood, like we have T cells and B cells, which play an important role in the immune system. They are affected, and there is decreased complement activation, decrease FC binding, and also we have recirculation immune complex deposition. So all these changes occur that can lead to the diffuse cutaneous leishmaniasis because of the impairment of the function of the humoral and cell-mediated immunity. The management of diffuse cutaneous leishmaniasis, again, these are the lesions of diffuse. You can see very big appearance, all the face is affected, and you can see all the papules, nodules, plaque, and there is diffuse infiltration. So that's the diffuse cutaneous leishmaniasis as compared to just the cutaneous leishmaniasis. Management is pentavalent antimonials 20-day course. Then we have an intervening drug-free period of 10 days after the 20-day course. And then we can also miltefosine for several months can be used. Paromomycin 14 milligram per kilogram per day. And we can also sodium stibogluconate 10 milligram per kilogram per day. So these are all the treatment options for diffuse cutaneous leishmaniasis. Then we have mucosal leishmaniasis. It involves the mucosa. You can see the site of involvement, mucosa of the oral cavity, lips are involved, then the nasal cavity is affected. It involves the mucosa of the pharynx also. So mucosa is affected in mucosal leishmaniasis. So we have visceral kala-azar leishmaniasis, most severe form, and then there is another forms which involves the skin cutaneous leishmaniasis, when it becomes more severe, more damaging of the reticuloendothelial system or the cell-mediated immunity or humoral immunity. We can have the diffuse cutaneous leishmaniasis. We have post-kala-azar dermal leishmaniasis. So the most common sites of involvement, we have viscera, then we have skin, we have the mucosal layer of the oral cavity, nasal cavity, and also the pharynx. So that's the mucosal leishmaniasis. So that concludes our topic of leishmaniasis, and we talked in detail about what is leishmaniasis, what are the different etiological factors of leishmaniasis, and how we manage and treat different types of cutaneous, mucosal, post-kala-azar, dermal leishmaniasis. Thank you for watching sqadia.com.